We are starting an introductory lecture for the one-piece AQB implant system, which is recommended for GPs. My name is Takaoki Nebuchi, and I am a former president of the Japanese Society of Advanced Implant Medicine, which is an organization of AQB implant users. The share of HA implants used in Japan is gradually decreasing as users age. However, users who have experienced the advantages of HA one-piece system are not likely to switch to the titanium two-piece system, and they continue to use the HA one-piece system with great affection to them. Some HA users may have experienced implant loss due to occlusal trauma and become frustrated. Some of the titanium two-piece users may be fed up with the complicated system. I would like to rediscover how such users can safely perform a simple HA-based one-piece clinical procedure. This is an introductory lecture condensed into about 80 minutes by the speaker, namely I, who have been exploring HA-based implant called one-piece AQB for about 40 years from upper serum. A HA-centered implant created in the mid-1980s until my retirement from clinical practice in 2023. The 80 minutes introductory session includes Part 1, Implant Treatment Trends over the past half century. Part 2, Basic Techniques for one-piece implant. Part 3, Features and Advantages of one-piece AQB. Part 4, Advantages and Disadvantages of HA implants compared to titanium implants. Let's move on to Part 1, Implant Treatment Trends over the past half century. In the 1980s and 70s, modern implants evolved from sub-periaustere implants, blade-bent implants, and bioceram implants. In the 1980s, Bronenmark implants were introduced to Japan, followed by the widespread use of titanium two-piece implants as the standard system. Since Bronenmark introduced the titanium osseointegrated implant in the 1980s, modern implants have rapidly become popular as a reliable treatment for dental defects with a stable prognosis. Titanium is an extremely oxidizable metal, and the net surface is covered with a coating of titanium oxide. Because titanium oxide is not easily regarded as a foreign substance by the living body, it has the property of contacting bone without fibrous connective tissue intervention when implanted in cross contact with bone without any gaps. This was named osseointegration by Bronenmark. On the other hand, in Japan, Institute for Medical and Dental Engineering, Tokyo Medical and Dental University developed hydroxyapatite implants, and in 1983, Asahi Kogaku Company Limited released Apaceram, the first apatite-centered implant that completely bonded to bone. Although it had the advantage of bonding to bone, it had the disadvantage of being rigid, brittle, and prone to fracture like a ceramic rod. Thereafter, HA-based implants have evolved by attaching or coating HA to the surface of titanium. If we classify the current implant treatment in terms of pieces, implants can be divided into three styles. The two-piece two-time method. First, a healing cap is attached on the fixture to be placed in the bone, covered with a mucoperiosteal flap and waited for osseointegration. Then a second window opening surgery is performed to connect the healing abutment and wait for healing of the gingival penetration. After that, the abutment is connected to the superstructure is fabricated. This is a two-piece, two-time implant method. The two-piece, one-time method. Instead of placing the fixture in the bone, a healing cap is attached on the surface with the fixture penetrating the gingiva and waiting for healing, requiring only one surgery. The one-piece, one-time method is an implant in which the fixture and the abutment are connected in a single unit. The rarity is that many HA implants are used because the abutment protrudes into the oral cavity and requires early bone union. Three implant styles and their positioning summary. The two-piece, two-time method is a prosthetic-driven system in which the fixture is placed with the expectation of bone augmentation if necessary, and the crown axis is adjusted with an angled abutment at a later date if necessary. The one-piece, one-time method is an existing bone center system in which the jawbone form and positional relationship with the contralateral teeth are observed in detail at the time of implantation, and the implant size and orientation are determined after careful consideration of which side in the jawbone to implant and in what size and in what direction. The two-piece one-time method is an in-between system. In ordinary plasma spraying, HA powder is instantly melted by a plasma flame at 15,000 degrees Celsius and adhered to the titanium surface, but impurities such as calcium phosphate and calcium oxide are also adhered at the same time. When we looked at the welded state, it looked like glass or syrup, and the function of hydroxyapatite was questionable. Development concept of one-piece AQB implant. The apatite synthesis implant upper serum made by Asahi Kogaku Company Limited, released in 1983, was the first revolutionary implant that bone can biointegrate, but it has a problem of being brittle and easily broken. After that, early HA-based implants that were plasma-coated titanium were problematic because of their low purity. To solve this, Advanced Company Limited developed a technology to plasma spray beta TCP, a precursor of HA, onto pure titanium and then convert it into a high purity recrystallized HA coating by hydrothermal treatment. In anticipation of the era of GPs rather than specialists in the near future, the one-piece, one-step method was chosen, and the surface is made of apatite. In the spirit of simple is the best, the one-piece AQB implant was born in 1994 with the aim of simplifying the implantation technique and materials. Purities and evaluation of HA coating. X-ray diffraction pattern shows that impurities such as calcium phosphate and calcium oxide are also adhered to conventional sprayed HA, and the peak of HA is low, but recrystallized HA shows no impurities and the peak of HA is high, indicating high purity. Scanning electron microscope image of the HA-coated surface shows that the surface is covered with apatite crystal structure. The titanium system requires a high surgical precision, but if the surgical precision is not high, fibrous connective tissue will intervene and cause areas where bone union does not occur, as shown in the pathological image. While the HA system has osteoconductive ability and can lead to bone union with the entire surface, with new cancerous bone, as shown in the pathological image, without requiring a high surgical precision. While it takes a long time for the pull-out test value to increase with titanium, the test value to withstand occlusal force is reached in 2 to 3 months with HA. In the one-piece and two-piece implantation experiments in dogs, the Advanced Company Limited Appetite Research Team, which was assigned to the Institute of Medical and Dental Engineering and conducted implantation experiments in the oral cavity of dogs and found no difference between the two-piece two-time method and the one-piece one-time method, at least in dogs. The history of development of AQB implant is as follows. The clinical trial from 1988 at Mitsui Memorial Hospital and from 1990 at the Nippon Dental University applied for and was approved by the Ministry of Health and Welfare in 1992 and was put on the market in 1994. After its launch, training sessions were held all over Japan. The number of users increased, and it is well known that it has grown to become the major HA-based implant used in Japan. The annual IAI research meeting, which has been held every year since 1998, became the Japanese Society of Advanced Implant Medicine (AIM) in 2008 and has been active as a general incorporated association since 2011. AQB implants come in 3mm, 4mm, and 5mm diameters, depending on the ratio of the length of the HA-coated root that enters the bone and the mirror-polished abutment that is exposed in the mouth. There were 21 product types when they were first launched, but this number soon increased to 27. In 2002, a two-piece system option was introduced, followed by a one-piece T-type with a tapered diameter at the cervical region in 2007. As a result, in 2013, the number of sizes of both straight and T-type in the one-piece category has increased to 33 varieties. Also for two-piece, there are 12 types. Incidentally, I am a one-piece person exclusively. The 2017 product list has the same types but at slightly lower prices. Next, we move on to the part 2, basic technique for one-piece AQB implant. The implantation technique is illustrated in the following step-by-step photographs of a surgical procedure for implantation in the lower right 7-6 area. For this level of surgery, we use about 3 xylocaine cartridges for a firm infiltration anesthesia. The incision is made at the alveolar apex using a feather number 15S as a bone scalpel. The gingival periosteal flap is then cleanly detached with a periosteal detachment tool to the extent that the bone width is visible. Initial guide hole formation and confirmation of implantation direction with a direction checker. The tool set includes a round bar and guide drill to form a guide hole to start, but because the guide drill has a low osteotomy ability at the apex, the performer first uses a prosthetic piece reamer with a sharp apex and a high osteotomy ability, although it is not included in the tool set. In the case of guide drill, if it hits hard bone while digging, it will shift and dig in the unexpected direction of the soft bone. The prosthetic piece reamer can form the initial guide hole in the expected direction. The diameter is then enlarged with a round bar and guide drill. Then the direction of implantation is confirmed with a direction checker, and in the case of multiple implantations, parallelism is checked. In the one-piece method, the initial guide hole formation is extremely important because it is an existing bone-centered system. In fact, the jaw-bone form and positional relationship with the opposing teeth are observed in detail during the procedure, and the implantation of which size in which direction and in which area of jawbone is decided after much deliberation. Formation of the implant socket with spiral drills. Once the implant position and the initial guide hole orientation have been determined, the next step is to enlarge the implant fossa to the desired diameter with spiral drills. For a 3 mm AQB, only a 3 mm spiral drill is used. For a 4 mm AQB, a counter drill is then used to taper the alveolar crest before using a 4 mm spiral drill. In the formation of a 5 mm AQB, a 5 mm spiral drill is used after a counter drill is used in the same way. As explained in the initial guide hole, the drill mainly drills the soft bony part, so the position of the implant fossa and the axis of formation are usually gradually shifted during the expansion. In order to avoid large buccal or ringer bone dehiscence, it is important to counter drill at various points to correct the trajectory so that the implant fossa can ultimately be formed in the middle of the jawbone. Enlargement with an end-mill reamer or reaming drill. An end-mill reamer is then used to flatten the fossa base. This is not a drill attached to an engine, but a finger screwdriver that is covered and rotated with the finger, like a root canal enlargement. When adjacent teeth is taller, reamer extensions are also available. The diameter is 0.25 mm larger than before, therefore diameter 2.75, 3.75, 4.75 mm respectively. When using spiral drill and reamers, the bone fragments collected in the groove are scraped up with tweezers and corrected on fresh gores and stored. This is so that it can be used as space making should a bone rupture occur during the last stage of surgery. The enlargement with a finger screwdriver is meant to remove the bone burn on the forming surface from the spiral drill used just before, but it is often difficult to flatten the fossa base in hard bone, so unless the bone is very soft, it is better to use a reaming drill attached to the engine before using end-mill reamer to create a dimensionally correct implant socket without blurring. Overall ranks of the trial guide and the model number of the AQB used. At the stage of end-mill reamer, the final diameter of the 0.25 to 5 mm narrow implant socket should be formed, and this is the stage to insert the trial guide into it to determine the module number of the AQB to be used. Although the diameter of the guide is 0.05 mm larger than that of the end mill reamer, it can usually be inserted with a certain degree of resistance. The depth to fit the trial guide can be inserted into the formed implant socket, and the distance to the opposing teeth by occlusion will determine the module number of the AQB to be used. For example, if the trial guide is inserted to a depth of 4 m and the clearance in occlusion between the guide and the opposing teeth is about 1 mm, then the 4ml AQB is the best choice. If there is a slight premature contact with the tooth, then the 4mm. If there is severe premature contact, then the 4ms, and so on. Final shaping and finishing of the implant fossa. The tool set includes a fine finishing reamer with a final diameter of 0.1 mm smaller. If the fitting of the trial guide is loose, it may be due to a shaky axis or soft bone and the process of the implant socket formation, and the finishing reamer should be pressed or not used. If there is difficulty in sinking or strong resistance to the trial fit of the trial guide, the finishing reamer should be used. Trimming of the gingival periosteal flap and implantation of AQB. Once the implant fossa is completed, trim the flap using a circular knife. We put the book-ringer flap back in its original position and cut the area that will cover the formed implant fossa. After that, the external hygienist take out the AQB of the model number to be used into the operative field. The surgeon inserts the AQB into the entrance of the formed implant fossa with his finger about half a turn, and it stops. The fixer is placed on top of the AQB, and the AQB is sunk while maintaining the insertion axis with the fixer support and rotating it with a free wrench. The AQB abutment has a notch to prevent the fixer from spinning. The notched surface is usually stopped in the book-ringer direction, but if you want to change the direction, it is advantageous to stop it in the proximal centrifugal direction. Postoperative and prosthetic fabrication. After implantation, search the gingival periosteal flap to complete the surgery, remove the whole cross, etc., and check the occlusal status and the usual treatment style. If necessary, the apex of the abutment will be ground with a turbine bar, chamfered and polished with silicone points to ensure a minimum distance of 1 mm to the contralateral teeth in occlusion. After surgery, dental radiographs are taken to check the implantation status, postoperative procedures, and medications. Patients are educated to avoid eating at the implant site for 3 weeks after surgery and to maintain rest to allow for smooth bone union. Postoperative medication such as antibiotics, anti-inflammatory analgesics, and antiseptic mouthwashes are prescribed to prevent infection and postoperative pain. Postoperative brushing. The next day, the wound is disinfected and cleaned, and if there is a poor blood circulation due to pressure of sutures, early partial suture removal is performed. Total suture removal is performed 5 to 7 days after surgery. 2 days after suture removal, the patient is asked to start brushing gently with an extra super soft brush for postoperative use, and to increase the level of brushing over 3 weeks, and then return to a normal brush from 4 weeks to 2 months. After surgery, we brush thoroughly and tighten the mucosa to its final form. This is a principle not only for implant surgery but for dental surgery in general. Next, we move to the part 3. The features and advantages of the one-piece AQB will be explained with examples of representative cases. Features and advantages of one-piece AQB. The following is a list of features and advantages of one-piece AQB implant as perceived by the speaker. I will now explain them in order from number 1 to number 9 using case examples. Features and advantages. Number 1. Both the form and procedure are simple and similar to natural teeth. The AQB to be implanted at upper anterior region tends to be protrusive. The starting point of the implant socket formation is placed in the palatal side of the jawbone, and the implant socket is enlarged and placed in the most favorable direction as far as possible. After suturing, the tooth axis is corrected to the palatal direction by forming the abutment tooth outline from the labial side. If an originate impression is made there, a resin temporary crown tech can be applied at the time of wound cleaning the next day. In this way, tech or crown can be fabricated in one piece just like natural teeth. Biointegration occurs around 2 months, so a final impression can be made, and the crown can be fabricated. The feeling is exactly the same as if the cast core were standing. This is at the time of maintenance after 6 years of implantation. Simple form and techniques similar to natural teeth prosthetics. Features and advantage number 2. HA-based give early biointegration and high occlusal support. In this case, implants were placed in a lower right 765 defects and restored with single crowns. This is the case after 6 months implantation, but the surgical invasion of implant socket formation temporarily left a mild slit-like bone form at the alveolar bone surface. This is 11 years after implantation, and vertical bone augmentation occasionally observed in mandibular motor area in HA-based implant. The following is a summary of the characteristics of bone bonding by biointegration. Early bone integration is the greatest feature of HA implants. After implantation, the mild dented cone-shaped bone formation that temporarily occurred by the surgical invasion of implant height formation at the alveolar crest caused will regenerate and become flat within a few years. In some cases, vertical bone augmentation can be observed in the mandibular motor area, as in this case, compared to titanium implants, which also integrate HA implants biointegrate. So X-ray images often suggest that the living body is obtaining bone form and creating the bone structure necessary for the implant to support the bite. As will be described later. There have been many experiences that make us feel that HA implants are living things, such as bone regeneration when appropriate occlusal adjustment is made to counter bone resorption caused by overload. However, don't overestimate the ability to support the bite. For more details, see Part 4, occlusal trauma and differences from titanium implants. Features and advantages number 3. 7 mm of space to mandibular canal is enough for 6 mm product. This case is a bilateral molar defect in the mandible, and 4, 5, 6 area on both sides were implanted in sequence. The left side 6 area was 5SS, but the right side 6 area was number 568. Because overly conscious of avoiding the risk of nerve damage, I implanted number 568. The model number was the shortest fixture, even though 5SS would have been possible originally. In the long term, I feared that the patient would suffer from occlusal trauma and have a short life. The patient's oral cavity and radiographs after 10 years were taken. As mentioned in number 2 feature, there is clear vertical bone augmentation has occurred at the alveolar apex. In the case of biointegration, it is thought that the organism has created the necessary bone structure to support implant occlusion. Thus, even in cases where the distance to the mandibular canal is short, 5S or 4S implants were used almost successfully. Features and advantages number 4. 3 mm product could be used for narrow bone widths. This case was implanted in a mandibular bilateral molar defect. The bone width of the right side crest seems to be adequate, but the left side is narrower, and 2 bicuspids were implanted with 3M, and first molar with 4M, and 3 connective crowns were planned. This upper intraoral bilateral view at the first visit. This is a patient who meticulously went for annual implant checkups, even after the implantation prosthetics. Lower left 4, 5, 6 area, 18 years after implantation, and lower left 7 treated by patient's request, 14 years, 7 months after. The patient is followed up every year, but even with 3 mm diameter molars, the patient is still safe as 18 years with connected crowns. Features and advantages number 5. Subgingival preparation is similar to natural teeth that guarantee aesthetics. This case is a patient who had 4 anterior maxillary teeth. The upper right tooth was extracted because it could not be saved. Later AQB was implanted at upper right tooth area. This is the impression of the 4 anterior teeth, and 4 single porcelain fused metal crowns were replaced at the patient's request. The following are the intraoral and dental radiographs taken at the 21st year of the patient's regular annual checkups. As you can see, aesthetics are well secured even with a one-piece implant. Features and advantages number 6. Can gradually transition to AQB crown bridge while using partial denture. In partial denture up to moderate defects, it is simple to cut out the denture base and the necessary area desired by the patient and replace the same area with AQB crown bridge. Let's summarize the method of transition to AQB for multiple tooth defects or edentulous cases. There are various cases depending on the condition of the jawbone and the patient's wishes, but I will try to categorize the cases of one-piece AQB implant treatment for the edentulous mandible. The simplest and most effective is bracket 1, bilateral 3-3 area implantations with a single crown plus partial denture. This prevents the denture from moving, which is good news for the patient. Next is bracket 2, bridge plus partial denture with bilateral 3-4 area implantations. Bracket 3, bridges with 3 implantations bilaterally so that the denture can be placed only on the molars. Bracket 4, if the patient wishes to have implants in all possible areas, then implantation in 5, 6, 7 areas bilaterally and restoration with crown or bridge will completely eliminate the need for partial denture. We will now review the procedure and the example treatment of bracket 4. The patient is a 62-year-old male, first seen in 2009, referred by a patient who had AQB implants placed at my clinic, has a relatively large number of remaining teeth, but in the end stage of chronic periodontitis in all jaws. The remaining teeth are upset and the patient wants to treat all possible sites with implants. The mandible and the maxilla were extracted in this order, and immediate denture was made. The mandible was made into a complete denture, and the maxilla was made into a partial denture with only the upper left canine temporarily preserved. First, cut off the floor of the lower right for 3 and 2 areas and implanted there. Then attach the 4-3 connected temporary crown and the 2 single temporary crown on them. After bone union, connected porcelain fused metal crown fabricated and 4-3 areas and leave the 2 areas as still temporary crown. Repeat the same things you did for the 2, 3, 4 areas at the lower right of it in turn for the other part of the body. Next, bridge is fabricated on the lower left 5 and 7 and the lower right 5 and 7 parts to be implanted and bridge. The mandible is completed. The same procedure is used for the maxilla with 4-3-2 area on the upper right and the upper left 2-3-4 areas, bridges in 2 parts bilaterally. Upper left was implanted in 5-6 area and single crown. Finally, upper right in 6-5 area and single crown. This allows us to replace the entire jaw with implants. The process of implanting the AQB, bonding the bone and inserting the crown, hanging the clasp to maintain the denture, and then moving on the next implantation area was repeated to gradually replace the multiple crown bridge of AQB. The implant prosthesis was completed after 2 years, 11 months. This overview is about 4 years after the completion of the treatment. Features and advantages number 7. No requirement for autogenous bone graft nor bone substitute during socket lift. The patient is a 41 female with a left upper 5, 6, 7 defect with a lowered maxillary sinus floor and extremely thin bone to the floor of the sinus. First, at upper left 5 areas, it was possible to implant without breaking the mucosa of the sinus floor, and the oozing elevated the mucosa of the sinus floor in a dome shape. When the bone in the same area about the floor of the sinus had matured, a resin crown was placed over it, and the same socket lift was performed in upper left 7 area. Fortunately, initial fixation was obtained in 7 area, and bone union was achieved smoothly. After the 7 area was integrated, resin bridge was placed, and weak occlusal force was applied to weight the bone density to increase. After 3 months of use of the resin bridge, a final impression of the bridge was made, and the final bridge was placed. As you can see in the dental radiographs, excellent bone has grown above the elevation of the floor of the sinus without bone substitute, and cortical bone has formed in the new floor of the sinus. The patient's subsequent progress was also favorable, and dental radiographs after 8.5 years shows that the organism has undergone a remodeling process to the minimal bone form required for occlusal support. Features and advantage number 8 can be used simultaneously with orthodontic treatment. A case of orthodontic treatment for maxillary prognatism with implants with an anchor. The patient was a 55 years old female. First visit 2004. At first, when at the orthodontist's office, refused orthodontic treatment because of many molar defects. She had a bite that was close to skeletal maxillary prognatism, with the mandibular arch almost completely inserted into the maxillary arch. Upper and lower premolars misaligned, lower bilateral incisors were congenital absent, and multiple missing molars in the upper jaw. Nevertheless, she wanted orthodontic treatment. The treatment goal was to implant AQB and the missing area of upper right 6-5 and upper left 5 as anchors. The buccally bulging upper right 4-3-2 was moved palatally to correct the dentition so that the patient could bite in the occlusal plane with the opposing teeth. After implantation, the AQB was covered with a resin crown and brackets were placed in upper right 6 to upper left 5 area to begin orthodontic treatment. The immediate goal was to move upper right 4-3 of the teeth palatally and started with nickel titan wires. AQB in upper right 6-5 and upper left 5 area as anchors could perform orthodontic treatment with an efficiency unthinkable in natural tooth anchor and with near supernormal stability due to the pressure drop of upper right 4-3 area and the contraction of the maxillary arch. The patient's occlusion is now stable and the AQB has been stabilized. The oral cavity and radiographs are 8 years 4 months after the completion of orthodontic treatment, and the AQB is still stable. Features and advantages number 9 can provide low-cost implant treatment. The price list for one-piece implant is 33,600 yen per implant as 2020 for all model numbers, and no other fees are charged. Therefore, it is possible to set up a low-cost implant treatment system. On the other hand, the two-piece type is 36,000 yen per fixture plus the cost from 27,000 yen to 32,000 yen per abutment. Various other equipment is also needed when taking impressions. In addition, many tools for two-piece implants need to be purchased additionally, and the laboratory technical fees of two-piece implants is considerably higher than that of one-piece implants. Therefore, it requires expensive implant treatment system. I hope you now understand the characteristics and advantages of the 9 items of the one-piece AQB. The last section summarizes the advantages and disadvantages of the HA-based system compared to the titanium-based system. Both systems are compared in tabular form. First of all, the basic structure of the system is the fixture into the bone and the abutment to cover the superstructure. Fixture and abutment are connected to form a single unit, screwed. Screwed connection at the depth of the bone surface. No need to screwing. Joint. The connection is made at the depth of the bony surface of the deep mucosa. No microgap-like joints. Numbers of surgeries. One-stage method is only placement surgery, but two-stage method contain placement surgery and window opening surgery to connect the abutment. Only one implantation surgery. Superstructure. There are two types, cemented such as crowns and bridges, and screwed through access holes. Cementation of crowns or bridges. Cost of materials. Many parts and materials and process of treatment, as well as high laboratory technical fees, must be charged at a high rate. Low-cost pricing is possible because the material cost is only for the implant body, and the technical fee is the same as for natural teeth. In the early stages of placement and implantation, if the initial fixation is loose, whether using one or two-stage technique, the initial stage of placement is not exposed to occlusal forces for a while, and therefore is not susceptible to occlusal trauma. But if a temporary denture is placed in the aesthetic field and then placed on top of the fixture for a while, it may be exposed to occlusal trauma and should be treated with caution. In one piece, the abutment protrudes into the oral cavity, so if the apex of the abutment is shaved and create enough clearance to make it less exposed to occlusal trauma. Bony union will begin in 3 to 4 weeks. Alternatively, temporary fixation with a nearby tooth or implant that is less prone to movement can lead to bone union. Post-implantation stage. Observation. The observation of bone union is difficult in the post-implantation stage because of the mucous membrane covering the implant in the two-stage procedure. In one-stage procedure, however, it is possible to observe the progress by percussion through a heating cap. In the one-piece method, the abutment protrudes into the oral cavity, allowing accurate diagnosis of the bonding state with the bone by percussion sound. The fabrication of superstructures such as crowns and bridges is an extremely complex process compared to a single piece. To elaborate a bit, in the two-piece, two-time method, the hearing cap is removed and the secondary surgery and the hearing abutment is placed and hearing is waited for the superstructure is fabricated. Prosthetics in two-piece, a complex impression taking and working model fabrication process is required unless the prosthetic abutment is screwed in place, and at that point it becomes a single piece. Before the superstructure is placed, the hearing abutment is removed and the prosthetic straight or angled abutment is screwed in place. There are also two-piece systems that are screwed in through the access hole rather than cemented together, which is extremely complex. In contrast, the one-piece system is similar to that for natural teeth, with the abutment formed and impression taken slightly below the gingival margin, allowing the crown or bridge to be placed. In response to overloading, namely occlusal trauma, bone resorption occurs from the superficial layers but generally progresses slowly. Because of the rough surface in HA, bone resorption can easily progress and become difficult to preserve if left untreated. Prevention and remedies include early detection by checking the occlusal status during maintenance and occlusal adjustment to reduce the burden and surgical procedures for peri-implantitis, but postoperative bone regeneration cannot be expected unless full-scale bone augmentation procedures are performed with membrane or bone substitute. In HA, if the occlusal condition is detected early by checking during maintenance and maintained by occlusal adjustment and surgical treatment, postoperative bone regeneration can be expected. If a healthy HA layer remains, damage of implant body. The frequency of loosening and fracture of the screw fastening portion is not infrequent in implant body damage. Until a decade ago, this was the biggest problem with two-piece implants. In HA, upset and dislocation due to cracks in the HA layer can occur. Strong clenching can also cause fracture in the upper part of the root. Prevention and remedies. Fractured screws are difficult to remove and generally require surgical treatment of fixture removal and reinsertion or stripping within the bone and change to other prosthetic methods. In HA, if there is no surrounding bone resorption, the removal of the superstructure and a period of unloading may result in rebiointegration. If reintegration is difficult, the root should be removed and reimplanted. If the fracture is in the upper part of the root may be extracted or stripping. Now that you have understood the importance of periodic checkups by maintenances for implant treatment, I will explain the points to be observed during periodic checkups in four categories. First, the characteristics of reaction of HA implants to occlusal trauma. The second, patients with strong occlusal forces who have prone to occlusal trauma. The third, occlusal position usually changes slightly over time, especially in patients with chronic temporomandibular joint disorder, but it is important to be careful. Finally, we need to pay attention to infection from chronic periodontitis of adjacent teeth or root apex regions, and we would like to remind the importance of periodic general dental checkups. First, let me summarize the differences between HA-based and titanium-based implants for occlusal trauma in the first section, the observation during periodic checkups. The greatest advantage of AQB implants, which are HA-based, is the phenomenon of the early bone union after implantation compared to titanium-based implants. However, after bone union and crown placement, I do not think that AQB implants can withstand stronger occlusal forces compared to titanium implants. Because the crown is bonded to the bone through a fragile layer called the HA layer, if tremendous occlusal forces such as crunching are applied, the HA layer may fracture, resulting in sudden dislocation of the last molar, or others with good surrounding bone without any slit-like bone resorption. Even in such cases, if the crown is removed or the temporary fixation with adjacent teeth and cured with occlusal forces, it may be possible to lead to rebiointegration, which has bone conduction ability not found in titanium implants. The speaker has been managing the occlusal adjustment of AQB implants for many years and have found that HA implants are living organisms. When the bone is in the state of hyperpermeability, this is a change in the superficial bone around the implant, which is a permeability stage of slit or mortar-like bone resorption caused by occlusal trauma, and the bone in the same area will show increased radiographic permeability. However, we have experienced many cases where healthy bone structures have regenerated in the hyperpermeability area by reading the signs on dental radiographs taken during periodic checkups and removing the overload by making appropriate occlusal adjustments. Here is one such case at the implant examination on 2015 January of a 73-year-old female who had been doing well until the third year of the implantation. A slight slit-like image of increased radiographic permeability was seen in the proximal portion of the upper right sixth after 4 months implantation. I thought it was due to overload, so I made a shaping adjustment to the marked points by articulating paper on the inner slope of the buccal occlusal surface. 1 year later, 2016 January, the upper right sixth was after 4 months. The proximal slit-like image of increased bone permeability deepened to the first thread, and the distal portion showed diffuse same image to the second thread, like a submarginal pocket. I determined that the overload had not yet been resolved by the occlusal adjustment of 1 year ago, and further occlusal adjustment of the marked points by articulating paper were performed. Another year later, 2017 January, The upper right 6 was 6 years 4 months, and the distal diffuse and proximal slit-like bone permeability images seen 1 year earlier were clearly regenerated by only occlusal adjustment to release the overload. The marked points were slightly occlusal adjustment again on this day just to be sure. A request for root canal treatment of upper right 5 was submitted to the client doctor for a root canal region due to pulp necrosis. Rarely, HA-based implants are living organisms. I will ask you to look at another case in which the patient was able to biointegration after dislocation. The case is a 63-year female with relatively remaining teeth, although maxilla had many upset teeth. Because the second molar has a low bone height diameter to the floor of the sinus, I planned to implant in the bilateral first molars, which could be implanted relatively safely by socket lift. The upper slide shows the upper left 6 at 1 year later examination. The lower slide shows the upper right 6 after 8 months and the upper left 6 after 1 year 4 months. At the time of the checkup, progress was good. However, about 6 months later, she came to my clinic because of upsetting of the upper left 6. Dental radiographs showed resorption of the peri-implant bone, which appeared to be dislocation. The remaining 10 natural teeth and the maxilla were pushed up by the opposing teeth during occlusion and swayed, indicating that the implants had been used as the final occlusal support. The sprint that had been made at the client's dentist's office were rarely used. Although there were some ups and downs, I decided to remove the crown to avoid damaging it and to monitor the patient's progress in the hope that it would reintegrate to the bone. After 2 months from crown removal, the motion decreased and the dental radiograph image showed bone regeneration around the implant. After 4 months from crown removal, a ridging crown was temporarily attached and waited for the bone union to become stronger. The upper left 6 was eventually remodeled with gold alloy crowns 9 months after dislocation. Center of slide reattached crown after 4 months. There is no overload image on dental radiograph. The lower right slide shows the oral cavity after 6 months of reattached crown. The articulating paper marks are evenly distributed between the implant and the natural teeth, indicating that the natural teeth and the implant are sharing the occlusal support properly. I'll say it again, HA-based implants are living organisms. Consideration of this case. This is not a typical jawbone form seen in patients with strong occlusal forces, but it is likely that the patient may have lost maxillary bilateral molars due to occlusal trauma, and even after losing occlusal support in the molar area, the remaining 10 maxillary teeth became relatively strongly agitated due to the strong occlusal forces. It is important to palpate the amount of protrusion of the maxillary anterior teeth before implantation by pressing the surgeon's fingers against the labial surface of the anterior teeth and palpating the amount of protrusion by the opposing teeth, and to know that when the implant crown is performed, to adjust the occlusion so that the amount of protrusion of the anterior teeth is the same as before surgery. This will ensure that the natural teeth and the implants share the occlusal force equally, and the implants will not become overloaded, and sudden dislocation will be less likely to occur. Next, I will discuss the characteristics of patients with strong occlusal forces who are prone to occlusal trauma in the second section of the observations during periodic checkups. Unlike patients who lose natural teeth due to chronic periodontitis, there are patients who have strong biting forces and tend to lose teeth due to traumatic factors such as crown fractures and root fractures. In such patients, the implants are gradually exposed to occlusal trauma due to abnormal occlusal wear and swaying of the remaining teeth, causing slit or mortar-shaped bone resorption, dislocation of the implant body, and increased risk of implant fracture. So, periodic occlusal adjustment management is extremely important for implant maintenance. Then I will try to summarize the methods of prevention and remedies for occlusal trauma. Patients with taut mandibular angles should be noted. I would like to talk about my experience through many years of clinical practice with AQB implants. As a theory based on experience, there are a cross relationship between function and form. Patients with taut mandibular angles naturally have well-developed masseter and temporal muscles, and their occlusal force should be strong. In addition, I believe that alveolar torus is often seen on the buccal-labial side of the teeth, and mandibular torus is often seen on the lingual side of the mandibular body. Even when chewing the same food, the masticatory force, bite force, varies greatly from person to person. Patients with taut mandibular angle prefer hard foods such as hard crackers, hard French breads, and hard nuts, which may easily cause occlusal trauma. They also seem to be more prone to occlusal trauma, namely teeth with advanced occlusal wear and tear for their age, crown or root fractures, or pulp-treated teeth that initially showed good progress are more likely to develop root apex region over time. Instead of causing damage to the teeth, the temporomandibular joint may be damaged, resulting in symptoms of so-called TMJ disorder. This is a panoramic radiograph of a patient who was seen by another dentist for implant request. The left and right sides of the radiograph are indicated. The bilateral mandibular angles are huge, showing the aspect of so-called gorilla jaw. In addition to the upper right 4 that was extracted due to root fracture, the proximal root of the lower right 6 and the distal root of the lower left 7 were also fractured. The lower left 7, despite being a living tooth, and a large apical root region was formed in the upper left 5 despite a firm root canal treatment, suggesting the involvement of occlusal trauma. Next, let's look at the third section of the observations during periodic checkups. which states that the occlusal position changes slightly over time. Enter. It is well known that occlusal trauma is often seen in the last molars, but we think it is important to be aware of the observation that occlusal conditions, not only implants, change slightly over time. Bite is a phenomenon in which the teeth of the upper and lower jaw function by contraction of the masticatory muscles with the temporomandibular joint as the fulcrum. The cartilage of the temporomandibular joint atrophies over time as a result of aging, and because there are differences between the left and the right sides of the joint, abnormal changes in occlusion can occur over time. It is necessary to read the occlusal changes during regular checkups and make appropriate occlusal adjustments to achieve a balanced occlusion of the whole jaw. Some patients with a strong bite who prefer to eat hard foods or who have a long-standing tendency to TMJ disorders sometimes come to the clinic with a sudden unilateral opening-like condition due to deformity, resorption, or deviation of articular cartilage or articular disc. In other words, only the last molar on the affected side is in occlusal contact and the contralateral side is open. In such a case, we use anti-inflammatory and analgesic drugs during the initial inflammatory phase and symptomatic treatment to adjust the occlusal significantly to achieve occlusal contact of multiple teeth on the left and the right sides as much as possible. The patient should then avoid the intake of hard foods and use aspirin to prevent recurrence once the occlusal condition had stabilized. Early occlusal adjustments may prevent deterioration of such TMJ-related occlusal changes, and it is important to check these changes during regular checkups. We sometimes see cases of long-term chronic TMJ disorder patients who suddenly develop unilateral open bite. The patient is a 66-year-old female who came to our clinic in 2021 April on the recommendation of one of our patients. She had TMJ disorder for a long time and had visited various medical institutions, including a university hospital. When she came to our clinic, she had occlusal contact only with the upper left 7 and the lower left 7, and no occlusal contact with the other teeth. The patient had been in this occlusal condition for more than a year, probably due to resorption of the cartilage of the left TMJ, and had been left in this occlusal condition for more than a year and had only received sprints in all medical institutions. At the initial visit, the crown of the lower left 7 was removed and the grinding and adjustment of multiple teeth was performed. This slide shows the occlusal state 4 weeks later with stable occlusion in all jaws. To prevent recurrence, an impression of the anti-clenching splint was taken on this day. This case is not an example of an implant patient, but we have experienced many cases of similar sudden unilateral open bite in implant patients with chronic temporomandibular disorder. And if the early contact tooth of the last molar is an implant, the implant will have problems due to occlusal trauma if significant grinding adjustments are not made in a short period of time. Finally, we come to the fourth section of the observations during periodic checkups. infection from chronic periodontitis of adjacent teeth or root apex regions. It is not infrequent that infection spills over from chronic periodontitis, apical periodontitis, radial roots, radial cysts, etc. in adjacent natural teeth while waiting for a visit, and periimplantitis develops. In this case, the disadvantage of HA implants compared to titanium implants is that HA implants have a rougher surface, so they are more likely to pick up infection from adjacent natural teeth and expand along the HA surface in a short period of time. For its prevention, regular checkups of the trinity of periodontitis, caries, and implants in daily clinical practice are irreplaceable. Diagnosis of treatment of peri-implant bone. If there are signs of increased radiographic permeability from the superficial layers or mildly mortar-shaped vertical bone resorption, radiographic checkup 3 to 4 months after crown placement will reveal the signs, and further bone resorption can be prevented through occlusal adjustments. For patients with clenching habits, nighttime sprinting can be used to prevent further bone resorption. Peri-implantitis due to peri-implant mucositis caused by poor oral hygiene or moderate slit or mortar-like bone resorption caused by occlusal trauma can be prevented by improving the level of tooth brushing during regular checkups, detecting bone resorption in its earliest stage, namely before it reaches the threads, and performing flap operation. If the subgingival pocket is brought back to the normal range by bone form correction, it is often possible to control the inflammation without recurrence thereafter. This is a summary of the advantages and disadvantages of osteoconductive ability, a characteristic of HA-based implants. Biointegrated implants are characterized by osteoconductive ability and bone union in a short period of time after implantation. Depending on the patient's bone forming ability, vertical bone growth can be seen in mandibular implants. Bone regeneration can be achieved by early detection and appropriate occlusal adjustment of mortar-shaped bone resorption due to occlusal trauma. And rebonding can be achieved by effective temporary fixation for sudden dislocation. I think it can even be said that HA is a living organism. While there are clinical cases that take advantage of such merits, there are rare but possible demerits, such as peri-implantitis caused by excessive vertical bone growth around the implant. So regular checkup is essential. Why does HA-based one-piece implant continue to be supported? Summary of this lecture. The answer to this question can be summarized in the 9 items in Part 3, Features and Advantages of one-piece AQB. Furthermore, the entire system may be summarized by the factors the first through the fourth shown on the next page and beyond. It seems that titanium-based two-piece implants are the gold standard, but I hope you now understand that HA-based one-piece implants are not to be abandoned. The first factor that summarizes the entire system. GPs are not implantologists or oral surgeons, and they regard implant therapy as routine clinical practice. Therefore, they are familiar with HA-based one-piece system, which are close to natural teeth, and they like the simplicity of the one-piece design. In other words, there is no risk to screw loosening or fracture, as in the case of a two-piece, and only one treatment step is required. The second factor that summarizes the entire system: GPs don't want to do extensive bone augmentation prior to implant treatment on a jawbone that is in poor condition, with severe bone resorption after natural tooth extraction. Also, there are not many patients who wish to go that far. Therefore, we feel that the HA-based one-piece is suitable for implant treatment planning that makes good use of the existing bone. The third factor that summarizes the entire system: once a surgeon reaches the point where HA implants are living organisms, he gains confidence and the ability to maintain implant stability by interacting with the surrounding bone through occlusal adjustment while viewing dental radiographs during maintenance. The fourth factor that summarizes the entire system: when he experiences that peri-implantitis can also be detected early in the maintenance and dealt with by occlusal adjustment and flap population. The current situation can be maintained, or even bone regeneration can be achieved if done well. He will be captivated by the one-piece HA system. I believe that the above factors that sum up the entire system are the reasons for the continued support of the One Piece HA system. Thank you for your attending my One Piece AQB clinical 82 minutes lecture today.